Okay, self-assessment for chapter 9, the patient with psychotic symptoms. A 78-year-old widow with macular degeneration is brought to her general practitioner by her daughter, who is concerned that her mother has been asking her to move non-existent dogs and cats off her couch. Her mother is otherwise alert, oriented, and in good health. What's the most likely diagnosis? A. Brain tumor. B. Charles Bonnet syndrome. Not to continue the options, so this is the answer, Charles Bonnet syndrome, but let's just, okay, delirium or dementia or schizophrenia. So the answer here is clear. So this is Charles Bonnet syndrome. Based on the information given here, Charles Bonnet syndrome is the most likely diagnosis. However, it's crucial to exclude delirium with a physical examination and cognitive assessment. Another case. A 62-year-old man with schizophrenia attends his general practitioner. He is disheveled and smells strongly of tobacco. He reports feeling that someone is pressing on his chest, particularly when he approaches the church at the top of the hill. He wonders if it is the devil. What's the most probable cause of the sensation in his chest? A. Delusion of control. B. Ischemic heart disease. C. Persecutory delusion. D. Tactile hallucination. E. Thought disorder. This is important actually, because the answer is, okay, this man has risk factors for ischemic heart disease, age, male, smoker, and so on, and gives a description of exercise-induced chest pain with a classic weight on chest description of that is typical for cardiac ischemia. So that's the answer, ischemic heart disease. But people with schizophrenia are at, and of course people with schizophrenia at increased risk of cardiovascular disease. Although this symptom could also be a tactile hallucination, it's important to exclude a physical origin before making this attribution. And you can see that the patient is making some, putting that symptom within the delusions. That doesn't make the symptom a false one. So you should consider ischemic heart disease. A 43-year-old man tells his general practitioner, "I think my wife is having an affair. She has frequently been coming home late from work, and 2 weeks ago he thought he saw her kissing another man. He is very upset by this and determined to get conclusive evidence to confront her with. He has quit his job to follow her and taken out a personal loan to purchase cameras to place in her car, workplace, and handbag. What is the psychopathology described here? Delusion, erotomania, hallucination, obsession, overvalued idea." It's obvious that the man here has overvalued idea, because delusional jealousy is the key differential here, but the belief his wife is having an affair appear to be based on logical grounds. So he cannot be said to be delusional. The belief is not considered to be described as recurrent or intrusive, so we are not talking about obsessions, of course. However, the impact of the belief on the man's life is substantial, as has become preoccupied with it. So that's why we call it overvalued ideas. Another question. A 19-year-old man is brought to accident and emergency by his flatmates because of the last fortnight. he has been complaining. The neighbors are talking about him, and tonight stated enough was enough and picked up his cricket bat to go and confront them. His friends cannot hear the neighbors. The man has smoked cannabis every day for the last 6 months and has recently been experimenting with some stimulant medication he bought online. What's the most likely diagnosis? A delusional disorder, depressive episode, severe with psychotic features, psychosis secondary to psychoactive substance use, schizophrenia, schizophrenia-like psychotic disorder. And the answer here is psychosis secondary to psychoactive substance use. This is the most likely diagnosis. Okay, but a definite diagnosis requires a longitudinal assessment, of course. The diagnosis would be confirmed if he stops using substances and his symptoms resolve. However, chronic cannabis use is a risk factor for schizophrenia actually, and if his symptoms persist despite abstaining from substances, this may emerge as the diagnosis, schizophrenia. Okay. But at this time, we diagnose the patient with psychosis secondary to psychoactive substance use. A 16-year-old boy is referred to a psychiatry because he has not been able to attend school for 3 months and has lost contact with his friends. He is very difficult to understand because his words do not seem to follow on from each other. Sometimes he laughs or grimaces for no discernible reason. What subtype of schizophrenia does he have? This is hebephrenia, which is, disorganized schizophrenia. Now to the extended questions. Differential diagnosis of psychosis. We have delusional disorder, dementia, delirium, depressive episode, severe with psychotic features, manic episode with psychotic features, neurodevelopmental disorder, personality disorder, psychosis secondary to a general medical condition, psychosis secondary to psychoactive substance use, schizoaffective disorder, schizophrenia-like psychotic disorders. So for each of the following patients, select the one most likely diagnosis from the list of options above. First, the mother of 22-year-old man asks for a home visit from their general practitioner. For the last 6 weeks, her son has barely left his home and seems to be collecting tinfoil. She is adamant that he has never used drugs. He is in second year at university, having passed first year with a distinction. But 6 months age, he lost interest. 6 months ago, he lost interest and stopped going to lectures. He tells the GP that a terrorist organization is trying to brainwash him into becoming a terrorist, and he needs the tinfoil to make it more difficult for them to beam thoughts into him. So symptoms for 6 months, and the age is about, we have some. Okay, the diagnosis here would be schizophrenia actually. Because this man describes the symptom of thought insertion. More than 1 month, of course. The diagnosis is supported by his age and functional decline prior to onset of symptoms. Although his mother does not think he misused substances, it would be important to exclude this by asking the man himself and performing a urine drug screen, of course. Another case. A 45-year-old man has recurrent episodes of low mood associated with third-person auditory hallucinations in the form of an abusive running commentary. These symptoms do not occur separately. So here we are talking about according to ICD-10, we are talking about schizoaffective disorder. So this man has current mood symptoms and first-rank symptoms of schizophrenia. So his mood and psychotic symptoms are equally prominent. So that that would diagnose a patient with schizoaffective disorder and make the diagnosis of depressive disorder with psychotic features as second differential. While in DSM-5, actually, we may say that this patient has depressive episode, of course. Okay. Another case. A 52-year-old man has recurrent episodes of low mood associated with second-person auditory hallucinations in the form of abusive comments. He has noticed his mood starts to dip first, and the hallucinations emerge as his mood worsens. So this is obvious. So here we are talking about depressive episode severe with psychotic features, because this man has mood symptoms and psychotic symptoms which are not typical of schizophrenia because they are second rather than third person. Mood symptoms appear to be more prominent than psychotic symptoms, making schizoaffective disorder unlikely here. Another case, a 47-year-old teacher present to his GP for a 25th time in 6 months, convinced he has bowel cancer, despite having had a normal colonoscopy and abdomen pelvis computed tomography. He tells his GP he knows logically he cannot have bowel cancer, but at the same time he is certain he does. His mood is normal and he is still working. So you are talking about delusional disorder, of course. He have long-standing unshakable beliefs. So it's about somatic beliefs. Okay, without any other psychotic symptoms, and with relatively normal functioning. Another case, a 37-year-old man who is brought to accident and emergency by the police for assessment after he called them to say his neighbor is persecuting him by refusing to move her wheelie pen. The police note multiple previous calls over the last decade about previous neighbors. The man agrees it is possible the neighbor has some other reason for not wanting to move the wheelie bin, but thinks it is most likely because she wants to spite him. He is angry with the police for bringing him to see a doctor, stating he plans to contact his lawyer about their behavior. So you are talking about personality disorder, it's obvious. So this man is not delusional, as his belief is not fixed actually. He is suspicious, yes, and that's why he called the police. The history from the police of multiple previous calls suggests his difficulties are long-standing. This would be consistent with paranoid personality disorder. However, a fuller background history would be required to make a definite diagnosis, of course. Another case. A woman requests a GP home visit for her 78-year-old father who has no previous psychiatric history. She is concerned that he has told her he can hear his mother and sister, who are both dead, talking. Okay. She is also concerned that he seems very forgetful and does not seem to be looking after himself properly. He is quite cheerful and enjoys speaking with his relatives. Here we are talking about, we have cognitive impairment, functional decline, auditory hallucinations. So let's get back to the options. It would be this option, dementia and delirium. It is in one option, but it is most likely to be dementia, but you need to rule out delirium, of course. You need to rule out delirium, of course. Okay. Okay. Another question, another extended question here. Psychosis secondary to general medical condition or psychoactive substance use. Amphetamine, cerebral tumor, cocaine, these are some causes and you need to match them with the cases below. So amphetamine, cerebral tumor, cocaine, corticosteroids, Cushing syndrome, L-DOPA, neurosyphilis, Huntington disease, hyperthyroidism, hypothyroidism, thiamine deficiency, and vitamin B12 deficiency. For each of the following patients, select one most likely cause for from the options above. A 62-year-old retired Navy officer is brought to his general practitioner by his wife. She is concerned that his personality has changed over the last few months. He has been unusually cheerful and keeps mentioning that he expects to be knighted for his naval service. He has become very extravagant, wanting to sell their home and give half the proceeds to charity. He forgot their wedding anniversary on examination. He has unusual brisk reflexes. So, for this patient, okay, his work in Navy, maybe it's about something to be outside home country, okay, outside the country, so that may be something here. And these clinical features are diverse, but can include, here we have personality changes, grandiose behaviors, and motor abnormalities like here brisk reflexes. All of these, if we put them all together, we should consider some infection like neurosyphilis, and it is the option here, of course, and it causes these symptoms. Okay, neurosyphilis is the answer. A 57-year-old accountant is brought to accident and emergency by the police after going to the supermarket in swimming trunks and flippers. He does not see that he did not see what the problem is. He states he wore the flippers because he has a constant headache which worsens when he bends down to tie his shoelaces. Okay. He has no psychiatric history or previous encounters with the police. Okay. So here we are talking about disinhibition. So this man is socially disinhibited with a headache, suggestive of raised intracranial pressure. Okay, so the diagnosis with the age, we are talking about cerebral tumor. And of course, if there's any focal neurological signs, that would further support the diagnosis. But roughly, this is the diagnosis, cerebral tumor. Okay, another case. A 46-year-old vegan goes to her GP because of the last 6 months she has found herself unusually clumsy, tripping over rugs and stairs in a way she never did before. She feels like everyone is watching her when she stumbles in the street and is sure she heard a group of strangers commenting on how they plan to rob her. So, yes, we have, okay, some ataxia and paranoid symptoms and so on. So, but we have a very important information here, which is the patient here is vegan, and you know, vitamin B12 deficiency here is the appropriate answer, because this woman is at risk for vitamin B12 deficiency, and she has the symptoms for that: ataxia, paranoia. All of these symptoms would be features of vitamin B12 deficiency. Anyways, a 42-year-old man is admitted for emergency surgery following a road traffic accident. 2 days after admission, he becomes agitated and asks the charge nurse why there are so many insects in the world. There are none. He keeps rubbing his skin and saying, "Get away, get away." He has a tumbling gait and his eyes make rapid small movements to the side and back again. So this man actually is likely experiencing vernix encephalopathy. He is experiencing visual hallucinations, Lilliputians, and possibly tactile hallucinations or insect beneath the skin. This is formication. He is ataxic and has nystagmus. Thus, he has the classic triad of vernix: confusion, ataxia, and ophthalmoplegia. Confusion, ataxia, and ophthalmoplegia. Although this man's alcohol history is unknown, the time course of these symptoms is consistent with the onset of alcohol withdrawal and alcohol use. So, you know, the patient is admitted, and after that, the symptoms after withdrawal are there. So we are talking about, you know, these things. Okay. Despite we are not talking about withdrawal, we are talking about thiamine deficiency, of course. But these would precipitate the symptoms in a way. Okay, let's continue. Mental state examination in psychosis, perceptual disturbances. Here we have some, you know, problems or psychopathologies, and we will match them with the next statements. Audible thoughts, extra-campaign hallucination, gustatory hallucination, hypnagogic hallucination, hypnopompic hallucination, kinesthetic hallucination, olfactory hallucination, pseudo-hallucination, second-person auditory hallucination, tactile hallucination, third-person auditory hallucination, and visceral hallucination. For each of the following patients, select one clinical feature described from the list of the above options. Okay. 1. I hear a man saying, "You idiot," in the corner of the room, but no one's there. So this is second-person auditory hallucination, of course. I hear a man saying, "You idiot," inside my head. Inside my head, this is audible thoughts. No, it's not audible thoughts, because he's not referring them to his own thoughts. So I hear a man, so another person, "You idiot," inside my head. So this is pseudo-hallucinations. So this is pseudo-hallucination. 3. I hear a man in Newcastle talking to me even though I live in Edinburgh. So this is extra-campaign hallucination. Of course, it is a second-person auditory hallucination, of course, because, you know, talking to me, but this is extra-campaign. My spleen is moving around inside me. This is visceral hallucination. Drifting off to sleep, I catch a glimpse of a ginger cat beside the bed, but I have no cat. As I'm drifting off to sleep, I catch a glimpse of a ginger cat beside the bed, but I have no cat. This is hypnagogic hallucination, of course. I taste rotting meat all the time. This is gustatory hallucination. So that's it for this. Another question. Mental state examination in psychosis. Here we are talking about thought disturbance. Previously we were talking about perceptual disturbance. Now we are talking about thought disturbance. So, delusion of control, delusion of infidelity, delusion of misidentification, delusion of reference, erotomania, grandiose delusion, loosening of association, nihilistic delusion, persecutory delusion, and somatic delusion. For each of the following patients, select one clinical feature that is described from the list above. First, I'm sure I'm being spied on by the government. I can't tell because of the amount of junk mail I get. So this is persecutory delusion. The second case, my boss definitely loves me, even though he denies it every time I remind him. Okay, this is erotomania. 3. I can't understand why that woman has dressed up as my wife and keeps referring to me as her husband. So this is delusions. No, not referral delusion. It's so okay. Again, I cannot understand why that woman has dressed up as my wife and keeps referring to me as her husband. So the patient is seeing his wife, but estranging his wife. So this is not Fergoli, this is Capgras. Fergoli, familiarize yourself with someone strange. On the other hand, Capgras, this is Capgras, yeah. This is delusion of misidentification. That was the option here, yeah? Delusion of misidentification, Capgras syndrome. Okay. The fourth case, the newsreader on the radio keeps reading out my name for some reason. So this is delusion of reference. 5. I don't need to eat because I'm already dead. This is nihilistic delusion. Someone else's thoughts are inside my head. This is thought insertion. This is thought insertion. It's not there. So it's delusion of control. Delusion of control. Mind control, of course. Okay. Why should the cat indeed bend that carrot tomatoes are red? What? Okay, again. Why should the cat indeed bend that carrot tomatoes are red? Of course, this is loosening of association, yeah. Okay, loosening of association. So that's it. هذا والله تعالى أعلم وصلى الله وسلم على سيدنا محمد وعلى آله وصحبه أجمعين. السلام عليكم.